Perfect. Good afternoon, everybody. Welcome to the Senate Education Committee. Today, Friday, February 12th. And can I please call the roll of clerk?
Senator Kalkin,
Present.
Senator Cano,
Present.
Senator DePalma,
Present.
Senator Gallo,
Present.
Senator Paulino, Senator Casala,
Present.
Senator Seveny, Madam Chair, there's 5 members present.
Thank you so much. At this time, I would like to call the meeting to order. And today we have a very important hearing on the youth in DCYF care and the post-treatment educational access at Bradley Hospital. We are discussing this important issue today because back in December, I was contacted by Mr. Paul Chappell about some children and young adults who were at Bradley Hospital for extended periods of time without receiving education services. Then a news report came out, and it was very troubling to me and also at that time our vice chairwoman, which is Senator Gallo. So we learned that had been some positive changes in the last couple of months, and hopefully it started to fix the situation and prevent it from happening again. We have several people join us today who will provide more details and then be available for questions from the committee. Mr. Chappell will also be joining us, and we hope to start without him since he will not be able to be here until 3:45 due to his work schedule. Because of that, I will invite all the presenters to remain online after you have finished, just in case Mr. Chappell brings anything up that you are able to address. Thank you all so much for taking the time to be here today. You do such hard work, especially when it comes to some of our most vulnerable children. We are all mindful that the pandemic has been especially hard on this group, so we want to do everything we can to meet their needs. I look forward to hearing your presentations and learning about what else we can do to help you and these children be successful. At this time, I would like to call the first item in the agenda, which would be the presentation by the Rhode Island Department of Children, Youth and Families and Office of the Child Advocate. So I believe that we have Acting Director of the DCYF, Kevin Alkin, with us today. Welcome to the Senate Education Committee.
Thank you, Madam Chair and members of the committee. Thank you for affording us the opportunity to present to you the issues and engage in a discussion regarding the delivery of educational services for children who are patients at Bradley Hospital. I should start by saying that DCYF certainly understands the value of ensuring that there is educational services provided to all children in the care of DCYF. And our case managers daily are in contact with school districts and local schools to make sure that we make the connections to help facilitate the delivery of educational services for children in care. I do have a slide deck, Madam Chair, that I'm hopefully going to be able to share if this modern technology works.
Absolutely, we welcome your presentation.
Okay, here we go. So in preparation for this hearing, we did receive certain inquiries from the committee members, so we tried to fashion this presentation to be responsive to those inquiries. The first issue is this is concerning the delivery of educational services when a child or an adolescent gets admitted into Bradley Hospital. It is very important to understand that with regard to Bradley Hospital, that is an acute psychiatric care facility that has a children's unit, an adolescent unit, and a unit for individuals, children with developmental disabilities. And I know Dr. Sachs will be in a much better position to be able to explain the operation of Bradley Hospital when he testifies. But what's also important to note that with regard to Bradley Hospital, they do have a capacity of up to 70 patients, and currently 15 of the patients are children in the care and custody of DCYF. Under state and federal regulation, okay, for a child who is admitted to a hospital setting, including a psychiatric care facility, the local school district is responsible for ensuring the delivery of educational support and services to that child during the child's stay in the facility. Historically, Bradley Hospital has worked very well with the school districts in arranging for the delivery of educational support and services to all patients at Bradley, not only the children in DCYF care, but all the patients at Bradley. In the past, the school districts have actually funded tutorial services that would be available that Bradley could utilize to help facilitate those services for these children. In addition to that, DCYF staff would supplement that effort by Bradley in contacting the local schools where the children had previously attended school to make sure that they were coordinating with Bradley on the delivery of educational services. In December, as you indicated, Madam Chair, after the concerns were expressed regarding the delivery of educational services, the department looked at its practice. And the department looked at the practice in terms of our staff reaching out to schools. We also had discussions with Bradley Hospital as to what their practices were with regard to the delivery of educational services. And I'll defer to Dr. Sachs. He'll be in a great position to be able to explain what they were doing. As a result of our review, at least internal review, we actually created a policy memorandum to our staff to enhance the efforts that our staff were making in reaching out to schools. So part of that policy memorandum, which ultimately became an operating procedure in early January, required our staff to not only contact the schools, but also contact the school districts. And then on top of that, we would follow up with Bradley Hospital, as we do every week. Bradley's clinical team would provide DCYF staff with an update with regard to their programming at Bradley and where they stood in terms of their care at Bradley. As part of that discussion, we asked our staff to check in on the delivery of educational services. If after 2 weeks no services were being provided, we asked that our staff follow up with our legal counsel so that our legal counsel, along with the efforts, and I'm sure you're going to hear from the child advocate, Jennifer Griffith, would also work with our efforts with the local school and the child advocate's office in problem solving these cases. If we could not problem solve the case, we did and were prepared to take enforcement action at the Department of Education in the event it could not be problem solved. I got to say that the next slide on page 4, reflects what is the status today. And I think, Madam Chair, you had referenced that there has been a significant improvement in terms of the delivery of educational services. And I think that's a testament to the school districts, to the treatment team at Bradley Hospital, as well as the case management staff at DCYF. So as we sit here today, of the 15 children and youth who are currently inpatient at Bradley, 11 of those youth we have confirmed are receiving educational services, and there are 3 youth that's in the process of coordinating the delivery of educational services between Bradley Hospital and the school districts. And there's actually 1 adolescent youth who was recently admitted into Bradley Hospital. So that process, the process I outlined in terms of Bradley reaching out to the school district, DCYF staff supplementing that and providing notification to the school and the school district, that process is underway, and we have all the confidence in the world that those, the 3 children we are in, there's transition planning going on now to deliver education, as well as the new admittance. Those children will all receive educational services shortly. On the slide to the right, on the same page, slide to the right, you asked for a breakdown in terms of the city and towns. We provided that for the 15 children that are currently in DCYF care and at Bradley. You can see that it's pretty well spread out amongst the city and towns. And these city and towns, as well as others, have been readily available to problem solve and to work with Bradley Hospital, DCYF, in facilitating the delivery of educational support services for the children at Bradley. I must also add, I'm not going to steal Dr. Sachs' presentation, but Bradley Hospital has worked both with school districts and with DCYF, and they are now utilizing virtual technology to support distant learning for the children and adolescents at Bradley. That is going a long way in terms of bridging the gap of educational services for the children at Bradley, and we commend them for doing that. You asked about how many children had been, and by age, had been discharged from Bradley Hospital for children in DCYF care. You'll see that the total number of children in this category was actually 351, and you'll see the distribution of their discharge on the table on the right. I must say that this between calendar years 2019 and 2020, of the children who were discharged during those calendar years, most of the children ended up going back to the facility or the home from which they came. So you'll see that a large number went back to residential treatment centers. That would be, some of those children would be residential treatment centers in Rhode Island where they had previously been placed. Many would go home. Many would go back to foster care or group home care. So it's important to keep that in perspective, that for the most part, of the children that are in Bradley Hospital, most have a placement identified from the time that they go in. And it's a question of when they are ready for discharge and when the provider, whether it be a parent, whether it be a foster parent, a group home, a residential treatment center, is able to have the child returned to them. Now, as we look at the number of children who are with discharge plans, you also asked about the length of stay for children at Bradley Hospital, and particularly children in state care. Before I go into the actual slide here on page 6, it's important, and I'm kind of borrowing Dr. Sachs' legal theorem, if you will, clinical theorem, that in considering the average length of stay for a child at Bradley Hospital, there are 3 factors that you have to weigh. One factor relates to the level of need for the child. The second one is matching that level of need for the child with an appropriate program. And the third factor is the availability of that program to accept the child. In years past, under normal circumstances, usually it's that third category, availability of the program to accept the child back into the program, that causes an extension of the child to have to remain at Bradley Hospital. And you'll see that the average length of stay in calendar year 19 was approximately 34 days, 35 days. The median length of stay 20. But in calendar year 20, okay, that jumped up to 56.3 days. Excuse me. Then you'll see on the slide on the right side of the page as to what happened with regard to the DCF youth and the average length of stay in the 4 quarters of calendar year 20. And you'll note that in the second quarter of calendar year 20, there was a doubling of the average length of stay for children and youth who were discharged from Bradley. Positive news is in quarter 3 and quarter 4 that we start to see that number coming down. I can tell you that for the 15 youth that are currently at Bradley Hospital today, their average length of stay is 36 days. So we're definitely trending in the right direction. But the issue here is what caused this? And I would tell you that it's very clear that when you consider that in quarter 2, we were at the outbreak of COVID, and that during the outbreak of COVID, particularly in the spring of 2020, we experienced a number of residential providers, congregate care providers, who limited and or stopped intakes into their program for purposes of containing and mitigating COVID spread in their programs. That had a clear and obvious impact and difficult impact, challenging impact on both Bradley and DCYF's ability to work to discharge children from the Bradley Hospital. The next slide accentuates that even more by showing how many children and youth were intaked and how many were discharged. I would point you to the time frame in April where the intakes clearly almost doubled the number of discharges, again in September, and once again in December. The reason why, in particular, April and December are very telling is those are the points where the state of Rhode Island was experiencing the COVID spread, the COVID outbreak, both in April, and clearly there were many programs that stopped intakes altogether. And then there was another outbreak after Thanksgiving in December. As we sit here today, I'm pleased to be able to tell you that with the decline in COVID positivity rates in the community, both in Rhode Island and our neighboring states, okay, we're seeing more flexibility, more open intakes into programs, which is clearly reducing the length of stay. I would only add in this, my presentation, I realize I'm watching the time, I would only add that this is not a phenomenon that was unique to Rhode Island, DCYF, or Bradley Hospital. This is something that was affecting children and youth in state care, both regionally and nationally. And it was based on the fact that as a result of COVID, there were many restrictions, limitations, and absolute holds placed on intakes of children and youth into residential settings. And it caused a delay in the discharge planning for children and youth in state care. So with that, Madam Chair, I will defer back to the committee and be available to answer any questions committee members may have. Thank you.
Thank you so much, Director. At this time, I would like to open for questions of any member of the committee.
Madam Chair?
Senator DePalma.
Thank you. Director, you don't have to go back to the slide. You have some excellent facts and data here. With regards to average length of stay, I'm not certain how to gauge that's good, bad, or otherwise. This one here. So I know what it says here. I know you indicate what the average is. Some of that seems like it's long, but it could be short, or it could be just right. I don't know how to gauge. How do I gauge in comparison? What can you maybe give us some, not necessarily today, follow-up data from other states on what they have? It just seems like 56 days is it's 2 months, right? That's a what drives the high end of the number?
Right. Fair question, Senator DePalma. We could get you historical data that we had with respect to average length of stay, let's say in calendar year 17 and 18 to put in perspective, calendar year 19 and 20. That would probably be the easiest.
I guess, sorry to interrupt if I may, I do have, because I want one quick question. I don't want to take too much of the committee's time, but also what can we expect to see from other states as well? So now, are we good? Are we not so good? We need to change something, or are we an outlier? So if you can provide that. Director, a more specific question, I'll say this respectfully, the children, youth, or whatever, that are at Bradley are a couple different categories, coming from, how do they get to Bradley?
Well, Bradley, as I mentioned, is an acute psychiatric care facility. They're admitted to Bradley based on a medical determination that they are in need of acute psychiatric care, generally related to their mental health and an acute risk that represents that they represent to themselves or others. And I'm sure Dr. Sachs will be able to put that in more proper psychiatric terms.
Again, maybe more specifically, we have having studied this a little bit over time, we have children that are there because they're in state care. Some are there because the parents have, I'm not sure what the word is these days, whether it's not Some of them because it's involuntary. The state just said we're doing it. They're ours now, and the state's care of them for various reasons. Other ones, the state has them for because the parents said, "Please, I need your help." And I don't know if there's other categories or not. Can you talk to the categories of students that are there?
Sure, and keep in mind that this presentation was focused based on the request we received from the Senate committee, and we focused on children in DCYF care. And I do want to point out that, in general, Bradley is not a placement. Bradley is an acute psychiatric care facility, and we would never want to place a child at Bradley while we were just waiting for another placement. So they had to meet a medical standard of care to be able to be admitted into Bradley. Now, separate from the children who are in the care and custody of DCYF, there are children where parents who have requested DCYF to assist them in providing residential care for their children. So they have facilitated and arranged for the admission of their children into Bradley. They retain all legal rights with respect to the child. And currently, we have 9 children that fit that category, where the parents have retained all legal rights, and they have requested that DCYF assist them in identifying an appropriate residential placement for their child based on the level of need, based on patient's need, and based on a match of that need to a program. And we have 9 children in that category.
Okay, so there's just the two categories then.
Yes.
Okay, there's not another category of, so there's ones that voluntary, or voluntary and involuntary, I guess.
The children in DCYF care could represent children who are involuntarily in DCYF care or voluntary in DCYF care. The second category of children are children that are not in the care of DCYF at all, and that the parent retains full legal care and custody of those children.
Really? And we have,
Yes.
so there's, Madam Chair, I just want to follow up.
Sure.
So we have the first category is bifurcated of voluntary and involuntary. And then there's a third category of the state's just providing the education for them, or the services for them there, but they're not. Okay, I guess I'm not quite certain what those 3 categories are, so, okay.
Thank you, Senator De Palma. Thank you, Director. I do actually have a question. How does the communication with the schools and the school districts actually work for both the initial contact and any follow-ups? Have the district been told about the new procedures so that they can have a designated person or someone for you to contact? Or is DCYF staff just calling the main offices?
Very good question, Chairwoman Cano. We are contacting the local school from where the child recently had been placed, and then we contact the school department, a contact within the school department that we use anytime we're dealing with determination of educational responsibility for a child in DCYF care. Those contacts have proven to be very effective because those are the same contacts we would use if a child was going from one group home to another.
So
Just
to be clear, yes, I'll get back to you. So just so I can be clear, so you have a designated person that you always call?
If we have a designated person that we would contact, and if they're not available, we would then reach out to any other person in the local school department's office.
Vice Chairwoman Gallo? Do you have a question?
It's Senator Quesada.
Oh, Senator Quesada.
Yeah, thank you, Madam Chair. My question is, I'm not clear. Looking at the chart, they said a youth can be at the hospital for almost 2 months, but who provide the education during that time that they stay in Bradley Hospital? Who is responsible to provide the education for those kids?
Okay, and going back to slide number 2, under both state and federal regulation, the responsibility is with the local school department, who is designated as responsible for the child. So that's why it's important. Sorry?
No, sorry, you continue.
Okay.
But my thing is, you said you had nine, I'm sorry, you had nine children at this time at Bradley Hospital. That means one come from Woonsocket, one from Providence, one from whatever other town. Then those schools are responsible to provide the education to them?
That is
Since they
correct.
are in Providence?
That is correct, that the school department who is responsible for the child, and this is the slide you're referring to, the school department that's responsible for the child would be responsible for coordinating the delivery of educational support and services to the child. Bradley Hospital, their treatment team have coordinated those services with these city and towns. Our responsibility is to supplement the notifications that Bradley is doing and how they're coordinating. We want to make sure that we're giving the notification to both the local school and the school district as soon as possible. The number of children in Bradley today in the care and custody of DCYF is actually 15. And those are the children that we are responsible to ensure that we are reaching out to the local school department and schools to make sure that they're coordinating with Bradley on the delivery of educational services.
It's Senator Quesada again. But who make the connection with the school? The social worker or the department?
The connection with the school is done twofold. Number one, the Bradley team also will connect with both the school and the school department and coordinate the delivery of services. Our social workers assigned to these 15 children also reach out to both the school and the school department to make sure that they follow up with Bradley Hospital on the coordination of the educational services.
Okay, thank you.
Thank you,
Thank you, Senator.
And thank you, Director. So can you explain to us what was the procedure for monitoring and communicating about the education service before you made these changes that you talked to us about?
Well, Senator, very good question. The department, I think, was assuming that after we connected with the school department, that the follow-up with Bradley Hospital with the school district would ensure that the educational services would be provided. Okay, we should not have been making that assumption. So as a result of that, we put in place this educational protocol to ensure that not only do we make the contact, but that we follow up with Bradley at each weekly meeting to ensure that the educational services are being provided.
So I agree with you, Director. That's good that you said that that assumption should have never been made. And I am very pleased to hear that you have come up with this policy and the procedure to make sure that communication is really straightforward with the local schools and districts, and make sure that follows to the end, so that the children in our care are receiving the education that they so rightfully deserve. So that is very good, and I really appreciate that. Does any other member of the committee has a question? I think Senator De Palma.
Thank you, Madam Chair. I will be quick on this. Director, just going back to what we talked about earlier and the children that are at Bradley. And I'll ask the same question to the Director Griffith when she comes up. DCYF is front and center on this, but it's really a three-legged stool, right? It's DCYF, if it's the Office of Child Advocate, and we have the family court. So we have the three-legged stool: DCYF, Office of Child Advocate, and I'll have the same question for the Director Griffith when she comes up, and the family court. How's the family court involved with this? With the same groups of folks we talked about earlier?
Well, I would say, Senator De Palma, just to put in context the question, the principals that are involved in terms of the delivery of educational services would really be Bradley, the local school committee, DCYF. Child Advocate is there to help support in the event there was an issue with regard to the delivery of the service. The family court on these 15 children who are in the care and custody of DCYF, the family court does have jurisdiction over these cases. And if there was a need, there could be an intervention in the family court to address this issue. However, by statute, if an issue came up with regard to the inability or the failure to provide these educational services, by law, the first intervention would have to be at the Department of Education.
Okay, I appreciate, thank you. I just wanted to, from an oversight perspective, I would think the family court would be integral with that as well. So thank you. Thank you, Madam Chair.
Thank you, Senator Palmer. Senator Quesada, do you have a follow-up question? Your hand is raised.
Oh, no, that was from before.
Okay.
But, it just, for me, it's just a comment, to be honest.
Sure.
I was very surprised that the only reason we find out about this is because the news find out that all these children were there for so long and they wasn't receiving the education they were supposed to be getting. I had a little knowledge of DCYF because when I work at John Hope, I used to work with DCYF. Then I know that many of those workers, and I put myself in their place. I was able to work with many great workers in DCYF in the past. And I know sometimes they do everything they can, but a lot of the time they have so much work, they oversee sometimes, those things happen. Then I do understand that. But thank you, Madam Chair.
Thank you. And Director, I really appreciate you taking the time to give us the overview today. Certainly, as I mentioned in my previous comments, I'm very pleased to know that there has been some things that have been addressed since the news report in December towards a positive change. And goes without say that I think that it's our responsibility to take care of these vulnerable children that don't have, in many cases, advocates. So for me, this issue is very important, and we will continue to work together to make sure that they receive that education that they deserve. So thank you so much. And if I could ask you to stay on, just in case there's more questions, that would be great. And I would like at this time to welcome our child advocate, Jennifer Griffith. How are you today?
Hello, good afternoon, Chairwoman and the rest of the committee. Nice to see you all in this new method. I was provided by your clerk several questions which you wanted me to address to you this afternoon. A lot of what I could say was a lot of what Director O'Coin said, so I'm just going to elaborate on some of those items. First of all, the first question was asked or posed to me was how the Child Advocate's Office provides or coordinates the educational services in DCYF. I think I know I've met most of you, of the senators. Hello, to those I haven't. I just want to let you know sometimes there can be some confusion to the differences between our roles. So I'm the director of the Child Advocate's Office. I provide, my 7 coworkers and I provide oversight to the entire DCYF operation. So we are 2 separate, distinct state agencies. And in that role, we do not provide any educational services, but we have been quite, I think, influential in the coordination of all kinds of services, specifically education. I would say that, when Senator Palmer referenced the stool, I would add it to more of a table, perhaps, in the idea that, it is the DCYF social worker. There is a family court attorney, a CASA attorney. We love an acronym in government, so I'll tell you, it's court-appointed special attorney or guardian for the child, along with the local educational agency and Bradley. And if there's an issue brought to our attention, our office is able to be involved. And I can assure you that we're heavily involved in many court cases way before this newscast ever came up. And we do take every call that we receive quite seriously. It's just that we cannot tell the caller exactly what we've done and report back to our confidentiality. I will say, since Director O'Coin has taken over as acting director, there's been a lot more communication and coordination, for which I'm very thankful, on all issues, but particularly with the Bradley issue. I think it's important for all of you to know, and I should just say, I see a black screen. I can only see Senator Palmer and Kevin. Is that okay? I don't want you to think I'm not making eye contact. Okay, so we get a weekly update of the young adults and children at Bradley or any other hospital-like setting. And we have added in, as Director O'Coin mentioned, a new, I guess, table or subset. There's a word for it in Excel, it's not coming to me now. A little block that would show the status, a cell, that's the word, the status of their educational situation at the time. And I do want to say that my assistant child advocate works tirelessly on education issues and involves herself every single day, emails and court appearances and calls, dealing with both social workers and the local educational department. The second question that was asked of me was to describe to you the factors that remain as of today in February that may delay. And I don't want to discredit the question that was given to me because I don't think it was posed in this way, but when it said post-treatment, and I'm sure Dr. Sachs, who is the medical doctor, which I do not claim to be, post-treatment, I just want to be clear that I have no knowledge or no reason to think that any child is post-treatment at Bradley Hospital. It's not as if they're separated out, those, who are receiving services and those who are not. That's never been the case at Bradley. So for me, as Director O'Coin mentioned, nationally and locally, there was a slight jam, for the best of words, as many placements did call Director O'Coin in the middle of the night in March and say, because I was the next call he made, we're going to stop taking kids, or maybe it's time to move some kids elsewhere. That did happen. And I think, nationally that happened as well. But I think to me, I think one of the most important initiatives I have embraced since I became the child advocate was the need to have a high-end residential treatment program, psychiatric, for adolescent females. Now, this is not my original idea. This has been a quest for decades for the Child Advocate's Office and, frankly, for DCYF, who's funded through the governor's budget, and not to speak for, but I believe the family court would agree with me. This is something I think the boys, frankly, have more options than the girls, and something I've been meeting with, and Kevin has been right there with me at every meeting, as has Senator DePalma. So I'm sure he would have extra insight for you if that interests you. The out-of-state programs, I don't mean to disparage those in-state that we use or to speak poorly of the...
Just give me 1 second, Director Griffith. Kevin, would you be able to just stop sharing your screen? I think that is the reason why we are seeing a black screen. If you can help us with that. I know we're learning this virtual setting together, so...
See, Kevin and I share so well. This is what we do. So
Good. See, that was fixed already. So thank you so much. You may continue. Thank you.
Oh, thank you. I thought it was me. So as I was saying, I don't want to disparage any in-state program or any out-of-state program. That's not what I'm here to do. I'm a former legal services attorney, so I'll be carrying that with me the rest of my life, and I'm thankful for that. But I will say, when we are using out-of-state facilities, we are putting barriers between these children and their families, and I don't like a barrier. So first of all, for the social workers who work at DCYF, if you're going to Vermont, that's a 6-hour trip up there and back, and you're not going to be able to bebop in and out if you were driving in Providence or Cranston or Warwick, or as I do in my office, we kind of sometimes have placements based upon where we live that we always go by. So the ones in my house see my face the most often. We do it that way. It just makes more sense. More importantly for me, when these young women are out of state, or young men, their families probably do not have the ability to have transportation. They may not have a car. RIPTA doesn't go to Burrville, never mind to Vermont or Western Massachusetts, and they may not have the kind of work schedule that would permit them to make a plan to commit to go see their child every other weekend. I know I couldn't afford to go to Vermont every other weekend. And to me, when they get out, I want them to have the same outpatient clinical treatment. Say you like your therapist. I don't want you starting anew with a new person. So for me, and also there's always less oversight of placement when it's 6 hours away, 2 hours away. So I could talk about the girls' treatment need. You all want to go home at some point, so I won't continue on that. But feel free to schedule any hearing. I'll talk till whenever. But could there be extra placements? Now, I will admit that the governor's last budget did have in it a proposal for 2 high-end placements. I think we could do more than 2. I know we could do more than 2. I think Kevin and I could fill a placement of 25 seats by the end of the day. But I will say, I think we really need to start the conversation of why don't the girls have a high-end treatment? It shouldn't be just relied upon the training school, which has its merits as well, and some placements here, but we need a high-end placement for these girls. The last question I was asked to discuss was if I saw any, what would increase the access. And again, I would say, education has changed dramatically from when I was in public school till now. It's not a case if you break your leg or you have the chicken pox or you had corona that you could go get books or dittos or anything like that. So, to make a change over, we also have to recognize that many of these young people, it's not clinically approved for them to have Chromebooks. We have many young people in placements in group homes that have to be supervised or right now can't use a Chromebook due to maybe material they might seek out or communications they may have. So it has to be a careful approach to educating these young people in Bradley. But I know from my conversations with Dr. Sachs, although I don't see him as much anymore, I was glad to speak to him this week, and I'm sure he can give you the most recent update on the hiring that they are planning on doing. I believe they have recently been able to hire someone or some people to be able to facilitate the education there. So that would be the gist of my presentation. As always, I'm happy to answer any questions that any of you may have.
Thank you so
Or
much.
about the girls' treatment. I'll talk about that too. So whatever you say.
Thank you so much for answering those questions and for being available today for the presentation. I actually have a question, and I'm not sure if it goes to either one of you. So you feel free to tell me who's best to answer this question. So the policy is unclear about when the child advocate receives a report on education service being provided to the students at Bradley Hospital. And memo that we received December 18, section B2 mentions a specific people. But B2A reference a weekly report for children in the community service and behavioral health unit that goes to the child advocate. So does the child advocate receive a report every week, or does she only receive a report every week if the child is in that particular unit? So for me, it's just a clarification question. And also to follow up, if the child advocate is not satisfied with those reports, what can your office do for that? Like, what can you just give us a clarification on that?
Sure, absolutely. So I'm not sure, to be honest with you, Chairwoman, which memo in December, but I would say this. I do receive a weekly report that lists the status. So once I know who is at Bradley or anyone in my office, I can then ask, because I can intervene on any court case of any child who's open to DCYF. So, for example, hypothetical answer to your question, if I were to find out that there is a child there, I'm making this up, this is not a real person. Sure. Say there's a child, Alyssa, 12 years old, a girl at Bradley, and it's been a week, 2 weeks, whatever the time is, at my discretion, frankly, I can file a motion in front of the family court judge. It can be emergency or already scheduled, and I can intervene. Now, not every case needs a court intervention, but I think as Kevin will tell you, I'm certainly not afraid of a court intervention. So I would tell you that sometimes it's helpful, and I think we can all learn from the idea of, does everyone know what's going on in the same building? And this is not to criticize any teacher. We could have called the teacher, but they didn't call the main office. They have also many things to do. So it's not always, I don't want to say anything negative upon any educator that when Kevin says, not to tell you what I think he meant, but what I meant, or I mean when he says that is, it's always important to include that extra person to make sure the circle's closed, so to speak. I have no reason to think that anyone permanent or eliminated that information, but sometimes children in DCYF care can move, and the school, they don't necessarily know how they're doing at their next place, but that can happen. Families can move and there can be changes. So we can intervene on any case. Sometimes it's a simple call to their CASA lawyer to say, did you know this is going on? And if they don't move with a certain speed, then my office will. So absolutely, we would get involved. And I think about the memo, they may have listed particular names, which is easier to do because there's only 8 of us. So it's not as if it's there's only 8 of us. Of course, 3 have the same name to make it easy. But I'll just say that if they're going to send it to one of us, we get it because we're all there together. If he listed 3 names, I would have to guess it'd be myself, the assistant child advocate, Caitlin Medeiros, and it probably says Catherine Cortez, who is my head investigator. I would assume those would be the 3. But we get the weekly report, but it's not as if as we're talking, the email popped up from Kevin's assistant to say, have a nice weekend, Jen. Here's your weekly Bradley report. Just as we were talking, it kind of just came up at a funny time. But if I saw number 17 on there, not to assign a child the number, it's not as if I have to wait to the weekly report. Kevin knows we talk every day. I could call him. I could call any of the staff and say, is there something I'm missing? What's going on? So I will tell you, Kevin, it coordinates with me. He couldn't be more coordinating or communicative in his way. If that answers your question, Chair.
Thank you so much. At this time, I'd like to call on Senator DePalma. I have some questions.
Thank you, Madam Chair. Director, regarding the first question I had asked Director Coyne about placement. So, and thank you for your work, all the work you do, and then some, and the Director Coyne as well. It's clearly the work that we're trying to get accomplished with Sharon O'Keefe as a major driver and Medicaid, with getting a in-state girls treatment facility to get it on par and parity with the boys, because the boys do have something that the girls don't have, and we need to, and there's money in the budget. If it wasn't the budget, we got to make it happen. I think this will be the time and year to make it happen. But given that, I would suspect that this is where I want to go back and see the time, but based on your experience, do we have children at Bradley that are there longer than they should be because they have no placement to go to?
Yes. Yeah.
Okay. Second, thank you. And I think I suspect then that when we see data from, well, maybe not prior years, because we've always had this issue, or other states on proportionally how that happens. But the follow-up thing with regards to so I assume you and the court, as the director indicated, have oversight of all children at Bradley within their purview of who's there and whether they're in state. I'm always going to get the term voluntary, involuntary, non-involuntary category.
Yeah.
So
Can I? Sure. The way I like to describe it to others is this. There could be almost 3 categories of young people who are at Bradley. Your first category would be your straight child welfare kids who are in the care and custody of the department. So these are the children or young adults who, as Kevin said, would go back to their group home, their foster home. Okay, so they're open to the department. There's an active family court case involving their parents and their family in family court at this time. That's the first group, as I see it. The second, and it gets confusing when you start using the word voluntary placement, because it just sounds strange together. As many family court terms, none of which I created or Kevin created, but that we've used along the way. So the voluntary placement process is a process in which a miscellaneous petition is filed with the family court. And this is for the population of young adults who have, extreme and significant behavioral challenges and developmental delays. Now, approximately at this time, my office, in addition to monitoring the approximate 7,000 children who are open and the approximate 1/3 of those who are not in their home, the training school, group home, foster home, medical facility, or out-of-state placement, we also carry a caseload, which is our guardian caseload. And I think, as Senator Palmer, you're familiar with Attorney Robbins in my office. That is also one of her responsibilities. The difference between the voluntary placement is that this is when parents, through no fault of their own, but you can cross over between child welfare to make it interesting. You could have a child welfare case, and you could have, two or 3 kids in a group home or in a foster home, and you can have a 4th who has these challenges or delays, and they're a situation where they'd be at Bradley. It can cross over sometimes. But a voluntary placement is basically saying, I cannot financially, and no one I know, all of us together with our incomes combined could not pay sometimes for the extraordinary cost it takes to care for these young people. The voluntary placements, the parents are saying, DCYF, can you place my child somewhere? I'm in agreement with this, but that child is theirs. They're not signing over anything. They have 10 days. They could say, you know what, I don't want this. I want the child returned to me. But this is sometimes a child whose, say, autistic needs have grown so great that they overpower the parent. Or as the parent ages, so does the child. And these are sometimes young people who transfer over to the Buddha system. So with the voluntary cases, my office, Attorney Robbins, is at every IEP meeting, every school function, every holiday function, she's at those group homes are on her circuit, that she's on every meeting, every call, and knows intensively each child or young person's cases. I think the third category you're referring to is a newer group. It's termed the funding source only. This was something that the past director had implemented. She felt that many parents had been surveyed and that they didn't want to be a part of, because I should have mentioned, when you're a voluntary placement, there are court dates, and many parents expressed a disinterest or a dissatisfaction that they had to be part of any family court case because they had done nothing wrong, which I can appreciate. But I'd like to contend if we approach the chief judge, again, I do not work for him, but I think he'd be inclined to say if we need to make a special calendar for that group, he would do so. So this third group, they do not get legal status, which means they do not enter the court system. So there is no court oversight. And selfishly, there is no appointment to my office. So there's no Attorney Robbins at every meeting. So there's a difference. So there are three groups, in my opinion: child welfare, voluntary placements, and the funding source only category. I hope that answers your question, Senator Palmer.
And the funding source only, could they be Katie Beckett kids?
I think sometimes that's more of a Medicaid direct issue with Buddha that I don't have as much experience. I don't believe, though, at this time, any of those young people are Katie Beckett children.
Thank you. Thank you, Madam Chair.
Thank you, Senator De Palma. Those are great questions. And just for clarification, I want to make sure that I kind of wrap this up. According to the presentation, the average stay at Bradley Hospital is longer than a month, right? We went over that. Are youth in treatment that whole time, or are there other reasons that might be remain at the hospital after the treatment is over? And we heard some of the reasons, right? Is one of the reasons voluntary placement? Can you elaborate on that? Are they all the time in treatment, or after the treatment is over, there's any other reasons that they remain in the hospital?
Are you asking me, Chair? I just want to make sure.
I could, either one of you, maybe Director.
I'll give it a go, Madam Chair. I know Dr. Sachs will be able to address that directly. It's my understanding that a child that is at Bradley continues to receive treatment, clinical services, psychiatric intervention through the date of their discharge. And I'm sure Dr. Sachs will be able to expound on that.
That would be great. Thank you. So I'll make sure I get back to that when the time is there. Any other members of the committee have any questions? That being none, the only other questions that I have is, have there been any hearing requests made by Rhode since the new policy started? We can hear you. You muted? Okay.
No, we have not received any requests for hearing.
All right. Thank you.
And Madam Chair, what I would say is that we built into our process a problem-solving component wherein we would reach out, our legal office would reach out to the local school departments, and in some instances, Jennifer's office is also involved. And to the credit of the department, to the credit of the school department in Bradley, those matters have been successfully able to get resolved before a need to file an intervention with the Department of Education.
Thank you so much.
Chair?
Yes. Vice Chairwoman Gallo, how are you?
I'm good. I apologize. I need to leave this meeting. I need to go to the Commerce Committee right now. So I apologize, but I'm going to leave. Everybody have a great weekend.
Thank you, Vice Chairwoman. I know what that is. I also have a hearing there, a bill there. So thank you. Have a great weekend.
All right. Thanks. Bye-bye.
Bye-bye. At this time, we'd like to call the next item in the agenda, and those are remarks from Paul Chappell, which is the behavioral specialist at Bradley Hospital, and the person that has been advocating for some changes, which we really appreciate, his advocacy and his passion, and I do know that he really cares about the job that he does and about these children. So welcome, Paul, to the Senate Education Committee. How are you?
Thank you, Chair. Thanks for inviting me to this meeting. I want to thank.
We are having some feedback. It may be because, give me 1 second. We're learning this technology together.
He might have his something on, either his audio loud, you can just put it lower down.
Sure. Mr. Chaplin, could you put your audio a little lower? Maybe that way we can hear you better.
How's that better?
Much better.
Okay, I want to thank Chair for inviting me to this meeting. I also want to thank everyone for gathering around my advocacy campaign to make change for the kids in DCYF custody. It's my privilege to be the voice, and I'm hoping that things will change as they have already. I'm very pleased with how everyone came together as a team to make positive change so quickly.
Mr. Chaplin, do you want to give us a summary of how you came about this information and maybe your experience as a behavioral specialist at Bradley Hospital?
Sure. So I've been working at Bradley Hospital for 10 years. I was also, back when I was 16 years old, was also a patient at Bradley. So I'm very passionate about the work that I do. And during the past 10 years, you know, it's been a nice ride, helping the kids. But the things that I see on a day-to-day basis, as far as how the kids staying at the hospital so long really affects them, it's really not a good scene to be in a crisis with a kid who's kind of, I don't know if I want to, stuck at the hospital waiting to go to placement. It's very sad to be in that situation. You got to kind of be in that situation, helping and trying to de-escalate to, you know, wrap your head around what the kid is thinking and how that can affect them and how can we help them better. And I just think that seeing that over and over again and not really seeing things get better really made me write the letter that I did back in July. So I wrote a letter to Kevin. We had a couple meetings. We had, you know, good conversation, but I didn't feel like there was not any movement as far as, or I didn't hear anything. So I decided to, you know, make conversation and advocate, and here we are today, you know, making positive changes for the kids.
And we are very thankful for, again, your advocacy. And the good news is that, like you said, there has been some policy changes that have allowed our DCYF department to communicate and make sure that they establish a communication with the school districts and to make sure that they follow through. And also, like we hear, the Child Advocate's Office is very aware and getting this report. So that certainly makes me very happy, and I hope that, like you said, we continue improving. Does anything? Do you want to add anything else? Have you seen any change? Do you still work at the setting? So do you want to add anything else?
So I currently still work at the hospital. Yes. I've heard a lot of good things that are happening. I think Rhode has given the hospital Chromebooks for the kids. They have implemented as times in their schedule on all units, children's, adolescent, and the CAD unit. They added time into their schedule for school. Adolescent is an hour and a half, and children's and the CAD program have 60 minutes each. So they're able to, I'm hearing good things from staff, from social work to doctors, and the staff that work with me, that things are going well. I also have some testimony from one of the kids who found out I was working on the overnight and stayed up to speak to me. And it was a patient that really struggled to work with me because I challenged her a lot, and she wasn't really a big fan. But once she heard what I did, she couldn't believe that I went that far to care about the kids in her situation. So her exact words to me were, "Paul, I heard what you did for us. This is quite admirable, actually. I never thought you actually cared enough to do something like that." So when she said that to me, that really made me feel good and for the work that I do. And I'm hoping that she's able to move forward.
That's really awesome. And what I say to you is that it's trusted relationships and people that are committed like you in these settings that make our children succeed. And so I want to thank you and every staff member that day and night take care of the children that are always there in in need of adults such as yourself. So I wanted to say thank you so much for your commitment, and thank you for coming in front of the committee. And I would like to open some questions for members of the committee if you have any for Mr. Chapu. At this time, I don't see any questions from members of the committee, but if you'd like to stay on for the next rest of the hearing, and you have any questions for any of the people that presented, please let us know, Mr. Chapu. And thank you so much for everything you do, and we continue following the process, and hopefully things definitely will get better. So thank you so much.
No problem. Thank you.
Okay, and next in the agenda is the presentation by Bradley Hospital, and we do have Dr. Henry Sachs, which is the president, and we are really happy to have you with us today, and I really want to welcome you to the Senate Education Committee. Dr. Sachs, how are you today? We cannot hear you, Dr. Sachs.
Unmute me. Okay, how's that?
Yeah.
Can you hear me now?
Now we can. Welcome to the Education Committee. Thank you for being here in a Friday afternoon.
Yes, and I guess I'm learning the technology also. Too many different platforms out there. Sorry about that. So thank you, Madam Chairwoman, for having me on and the committee. And, to talk about what is an important and passionate subject for me and for a lot of us here at Bradley Hospital. I wanted to first, for a moment, just to acknowledge Paul, who's been a long-standing employee here at Bradley, and not only for that, because he worked for literally the work he does every day with the children when he is here. He's we ask. It's a difficult job to be a behavioral health specialist. We ask a lot of them. It takes a certain character to be able to do it effectively and therapeutically. And Paul has been able to demonstrate that for many years, and it has made a difference for the kids, whether they always appreciate it or not at the time. I would also like to just take a moment to acknowledge that we've obviously taught Director Aquine well, because he did a great job of talking about a lot of things that go on at Bradley Hospital and did it as well as I could. So I'll hopefully be able to be more, not going to as much depth on some things. I think just for a moment, I'd like to just start out and putting things in a bit of a context for this discussion. I did send in advance to Ms. Crowley a PowerPoint that sort of gives the levels of service Bradley has. I'm not going to go into those in detail, But to understand us as and what we are, we're the first freestanding child psychiatric hospital in the country, probably in the world. We've been here since 1931. And with that long history, we've been able to do something that's truly unique. There really is no other Bradley hospital in the country, and probably in the world for that matter. Over time, we've been able to create what we call a continuum of care, taking care of children in our inpatient units, creating and then having the levels of care to help them, support them, so that they don't have to spend as much time on inpatient level of care and can get the lower levels of care, less intense levels of care, quickly and get ongoing treatment until we have them fully stabilized to return to as normal a life as possible at the time they leave our services entirely. So we have 70 inpatient beds that are divided between 3 different populations: adolescents, children, and those with autism and developmental disabilities. We have about 120 partial hospital slots, which are children here basically 6 hours a day, 5 days a week for anywhere from 2 to 4 weeks, receiving services. They get to go home at night, but we do a lot of intensive services with the children and the families and those things in that role. We have 74 residential beds divided between adolescents, younger children working towards family reunification, and those with developmental disabilities. We do in-home services. We have a school for over 400 students, and then we see approximately 3,500 outpatients a year, 35 individuals, many more, obviously, visits per year. So it's really a spectrum of care that doesn't exist anywhere else. And one of the reasons we've had to build that spectrum of care is that over the last 15 years at least, there's been an ongoing significant increase in the need for child behavioral health services nationwide. This is not at all a unique Rhode Island situation. Between the years of 2008 and 2015, there was a 100% increase in the number of children who sought inpatient hospitalization for suicidal ideation or suicide attempts. And since 2015, unfortunately, that number has only increased dramatically, even before COVID-19. Before the pandemic began, the rate of suicide in the United States in the previous 3 years for adolescents, and in this case going from 15 to 19 was the numbers measured by the CDC, had increased by 24%. In just that 3-year period, and for the state of Rhode Island, we're very fortunate that it's actually decreased 41% in that exact same time frame. And a lot of work that has been done between Bradley, the state, and RISAS have been very important in addressing those issues. And we have 2 pandemics now. One is clearly COVID-19. The other one, which is going to be with us much longer, is the mental health pandemic that is secondary to it. Talking about a surge on top of a surge, we've had a mental health surge, a behavioral health surge for months, years, and that surge is only going to be intensified by what's happening now. And we've seen that in our results. So that's just to put into context a little bit what has been going on. As far as since the pandemic started, just as an example, emergency room visits for children in the pediatric population in general has gone down fairly significantly. However, for those presenting with psychiatric issues, suicidal tendencies, self-injury, aggression, and other behavioral health issues, the percent that has gone up for children for children has gone up 24%, and for adolescents has gone up 31%. That is just in the last year. And that really reflects a reality we're seeing where adolescents in particular have been devastated by this pandemic. And I think the long-term consequences we will be facing for quite a while. In regards specifically, and I could go on about all these things, and I will not do that. I will I'll be glad to answer any questions. One clarification I do want to make, and because we were talking, and this is more to Senator DePalma's questions and the clarifications. There's really 4 classes of patients at Bradley Hospital. Not to correct Ms. Griffith, who we work with very well over time, but we have those who are in, in the care and custody of DCYF, those in voluntary placement, those in funding source only situations with DCYF. But the vast majority of our children we care have nothing to do with DCYF. The vast majority probably don't know how to spell DCYF. That's a bad joke, but really are not involved. And I just wanted to make that very, very clear. And we seek educational services for all the children who are admitted to our care, and we always have. Up until prior to the pandemic, the challenge had been when children came in, we would call up the school district. We call the school districts for two reasons. We call the school specifically for two reasons. One is it is to obtain information about the children who are admitted to us. We need to know their psychiatric status, what's been going on in the school setting. It's a very important part of information in our treatment. So that's a key reason we had contacted the school. And then the secondary reason was also to set up their ongoing education. Some of that would be done directly with the school, and then others would be sort of a back office discussion between our business department and the school district, because the school district would be expected to pay for tutoring services. Throughout time, I think it's fair to say that it was a very confusing situation for everybody. We would send out requests for tutoring for patients as they were here for an extended period of time, and we had variable responsivity from school districts on how fast they would return the necessary signed documents, how many hours they would authorize, when would it could start. Some said, well, we won't do it until 30 days out from 30 days in the hospital. Others would do it immediately. Sorry. And then one of the other big issues, especially before the ESSA transition and even early in the ESSA transition, was school districts would say, for those in DCYF custody, well, that's not our child, that's someone else's child. And then would be a decision about which school district had to take responsibility for the child. We, in general, provided the tutors in those situations, and we would be paid by the school districts. Certain school districts, such as Providence, demanded, because of union contract, that they send their own tutors. So they would have to send their own tutors, and that was always a challenge because they'd have to be specially trained by us around HIPAA issues, their own safety on a psychiatric unit, things of that nature. But we had tutors. Just before the pandemic started, we lost one tutor, and we were trying to hire, and then soon after the pandemic hit, we lost our second tutor. And we've been searching for tutors ever since. As I'm sure many in this committee in particular would know, having adequate teaching resources is a major challenge right now. It continues to be for us. We've been, just yesterday, we had a tutor turn down an offer to work with us. So we have not been able to bring a tutor in to replace those. One of the advantages of the pandemic has been the real enhancement of distance learning in all the school districts by need, and we have now incorporated that into what we're doing here. The reality is, besides just the length of stay, the kids stay that Director O'Quine mentioned before, one of the other issue was the acuity of the patients we treat has been increasing again from before the pandemic for years, and has only been more severe with the pandemic. We see far more severe episodes of suicidality and suicide attempts. We see far more behavioral dysregulation that has only been accelerated during the pandemic. And up until 2 months ago, it was actually unsafe for us to do distance learning on our inpatient units because using a Chromebook would actually be literally dangerous for the patient and those around them. The good news is the acuity has diminished over the last couple of months, and working with DCYF, working with Ms. Griffith and others, we've been able to implement what is now a distance learning model for all of our students, all of our patients. We have set up blocks of time so that those in the units can connect with their school district, and it's up to the school district to determine what type of connection that is. Is it with a tutor? Is it to join and engage in what's going on in the classrooms they would be attending if they were at school that day? We allow them to arrange that. The school districts in general have provided all the children with Chromebooks, so they bring that in, we store them, we charge them, we take care of them. We've hired we're in the process of hiring, we've given someone the job, but we're in the process of hiring a educational coordinator, because this is when you have 70 children on inpatient units. It's a very complex thing to make sure that all the kids are hooked up to the right programs at the right times, and we are still looking for a tutor, because we also think that while we're even doing this with our young children, our kids with developmental disabilities, the reality is that for them, probably having a tutor would be more effective than not. But again, that's a challenge as far as recruitment goes. So we've been doing all of these things. We've gotten good response from the school districts. I think there's still some growing pains with this, but it has been a positive transition we've been able to do over the last few weeks, and we're looking forward to it to continue to be more standardized across all the districts. The one final comment that I'll be going to and others is I think Director O'Quine mentioned this, and Ms. Griffith definitely did, is when we talk about post-treatment, our goal is to always have children discharged as soon as they're clinically stable enough to go to a lower level of care. Being in an inpatient unit is not where we want anyone to be if they don't need to be there. That being said, there are some children, as Director O'Quine said, we have to have the child be stabilized, understand what their needs are, and then have a bed available that meets those needs. And we do occasionally have a subset of patients, far from the majority, but a subset who are in that position where we think they're probably clinically stable to move to a lower level of care, and that bed is not available for them. Those children, if you walk onto our units, are entirely indistinguishable from everyone else that is we treat. They receive psychiatric treatment every day. They receive counseling. They have nursing care. Literally, they are totally indistinguishable for everyone else who we serve. And that's because they're not cured. They still need a lot of treatment, and where they're going, they're going to continue to get treatment. But they are in a position there. If a bed was available, we would feel comfortable transitioning them. We meet every week with DCYF, working. We have a very good collaborative relationship, trying to move children as effectively as possible. This past year, when the pandemic hit, almost every residential program in the state closed. In fact, the only one that didn't close the front doors were ours, so we could send them to our own residential programs. All the out-of-state placements were not allowed to take children from across state lines. So that number you saw, this remarkable increase in the length of stay of children requiring placement, was an unfortunate reality of that situation. It is much better now. We see things flowing, and we're hopeful that we can get back to a status quo and even get better, improve beyond the status quo we had. And I strongly endorse Ms. Griffith's comments about an adolescent female in-state treatment program. It is desperately needed. That is the single most challenging population to move on from our program to where they need to be, just because of a lack of in-state resources for them. So I've rambled on for a while there. If people have questions, I'll be glad to answer them. And if I've missed anything, please let me know.
Thank you so much, Dr. Sachs. You were very clear and certainly answered so many of our questions, at least my questions. And just for clarification purposes, I know that we've been talking throughout the whole hearing, and we have heard that there are times when the youth remain Bradley after their treatment is over, but you clarified that they continue to receive the treatment and that they may be ready to move on, but because of the difficulty with placement, you will transition them and distinguish those patients. So I really appreciate that clarification, and I just want to make sure that if we could do anything to help that make easy, what would that be? I just want you to give us advice on what would that be to make it easy.
Make my life easy or make the kids' life easy?
The kids' life easy, for sure. Even though I would like to make your life easy too, but in this hearing particularly, I want the children's life to be easy, and for sure, you know where I'm coming from. Yeah.
So absolutely. I think, and again, I think that the good news is there's a lot of really goodwill and a willingness in the state to work on these things. And from our perspective, I am a zealot in believing that children shouldn't be in a level of care longer than they need to be and to move them on. We have a lot of resources in the state to do that for a large percentage of the children. There are as I said, there's one major subset and maybe a little more minor subset where it's a real challenge at this point. One is for those adolescent females, often who've had really traumatic histories, who are highly dysregulated, engage in very dangerous behaviors, often self-harm to themselves, and they require often rehospitalization over and over again. Having an effective treatment program in state for that group, so not only can we get them in quickly, but they can stay integrated with their families, as Ms. Griffith mentioned. And you can have a much better step-down plan for them. One of the great frustrations is when a child has been sitting in a residential program out of state, stabilized there, got great treatment there, but didn't really integrate their families. They come back into the state, and within 24 hours, they're in the emergency room. That's months and months of work that has been wasted to a large extent. And to the extent that we could keep them in the state, keep their care here, have that more be effective, I think is the single most important thing we could do. The next group that's a smaller group than that actually is those with autism and developmental disabilities. There's a certain level of high-end need that we have to go out of state for, which would be nice to have in state. But that to me is old. If we're going to pick one, if you wanted to make everyone's life better and the children's better, it would be that high-end need adolescent female residential program with on-site education resources.
Thank you, Dr. Sachs. And also, I know that our child advocate also mentioned that. So I really appreciate that feedback, and hopefully we'll get to a point where we could definitely make that happen. At this time, I'd also like to open questions for any member of the committee. If no, I have some other questions as well. So does any member of the committee have a question this time? It seemed that Senator Calkin, welcome.
Thanks. Dr. Sachs, and maybe anybody else can feel free to jump in. I'm assuming that, children under DCYF care, there's things happening, so they're having to deal with those family situations. Something else is happening that causes them to go to Bradley. So they're dealing with a lot, plus COVID and everything else. Have you seen that inclusion of the education program that you're putting in place is helping them by kind of giving them a sense of normalcy a little bit, or is it adding stress to, a situation that they're already dealing with? What has been your experience so far with the kids that have, and maybe with these 15? Can you maybe give us some insight?
Sure. I think it's fair to say we've seen both. We've seen some of the children who, sometimes school-related issues are what trigger why they're in the hospital. But I'd say overall it is been well received by the kids. I think for those who've been here longer, it's sort of getting back into the routine of doing it has been a bit of a challenge. But in general, I'd say it's well received. It is a sense of normalcy. One of the struggles we see, not so much with our DCYF kids, to be honest, but with other kids, is one of their biggest anxieties is I'm falling behind in school. I'm falling behind in school, even if they're there for a week with us for a week, and so they want to get out of the hospital just so they can catch back up. So to the extent that we can do things to minimize that, it is, I think, in everyone's best interest. And school is part of being a kid, and so having them do that is really important.
Thanks, I appreciate that. Yeah, because I imagine being out of school for any length of time can be give anyone anxiety. You always, you have those nightmares of missing a test and things like that. So I appreciate that, and I appreciate the work that you're all doing to try to help these children and make sure that they're educated and everything. So I appreciate the new process. So thanks for that.
Thank you, Senator Calkin. And President, I also like to make sure that I highlight that you have stated in your remarks that you have a new process for distant learning, and that is great to hear. But before COVID-19, can you give us a little insight of what role did Bradley start playing, providing education service to youth admitted to the hospital?
So prior to the pandemic, we hired tutors to provide those services. So we would have two tutors. One was for our younger children and those with developmental disabilities, and one was for our adolescents. The challenge we had challenges, and particularly with the hiring of a tutor for the adolescent program, even before the pandemic. And I, Paul has mentioned that in the past. So what we ended up, our staff, what ended up happening before is that often we would ask the schools, often through the families, to send us packages of education materials, and then our staff could sit down there and, support the child in doing the work. We weren't teachers. We couldn't take on that role, but support them in actually keeping some level of work going on while they were there. In our younger programs, we had the tutor come in and work with each child individually or in small groups, depending. One of our challenges is you have to match developmental skill set together. So some children could be much older in age, but their academic skill sets were such that they would have to be with younger children. So trying to mix and match that so it would be effective for those was done. But once the pandemic hit, and we lost our tutor, no other tutors could come in. We continue to just find it a challenge. Even the Bradley School, which is a well-respected special education school for us, we have 7 unfilled teacher positions right now that we've had for weeks, for months, I should say. So it's just finding teachers who are willing to work with this environment, willing to work with the pandemic, and all the challenges it brings to teaching has obviously impaired that resource to some extent, and then obviously having a willingness to work in a psychiatric hospital with high acuity and associated risk potentially also diminishes the number who might be interested.
At this time, I think it would be good to mention that you have stated before that you're looking for a tutor. So any viewer that up there that that could help the president here, they're definitely looking for tutors. So thank you so much for that answer. And you brought an interesting point there. I wonder if there is any relationship between Bradley hospitals and Bradley schools. So can you elaborate on that?
Well, yes. At one time, Bradley School was literally part of Bradley Hospital. It was just another division. It is now an affiliate of Bradley Hospital. So Bradley Hospital is the sole corporate owner of Bradley School. So we have a very close relationship. And in fact, our tutors are actually provided to us by Bradley School. The tutors the tutors are hired by Bradley School to come work on our setting. That is where our educational expertise is, and we're very proud of that educational expertise, as a matter of fact.
That's great. So that being said, I need to correct myself. They need to contact the Bradley schools, right? Okay. If any member of the committee have any other questions, this is the time to ask Dr. Sachs. If not, more questions. The last question that I have for you is, what do you think would be the best way for Bradley, DCYF, school districts to coordinate to make sure that youth are receiving the educational services they're entitled to in youth care? Do you think that the steps that we heard today are enough, or is anything else that you'd like to add?
I feel relatively confident that if the steps that were described today are sort of routinized and become hardwired for Bradley, for DCYF, and for the school districts, that would be a very effective process that I think will work well. I think one thing just to highlight, often in the first few days that a child is in Bradley Hospital, they're not ready for educational treatment. There are reasons they're here, and we need to stabilize them enough to even have to access the resources that the schools can provide at that time through the distance learning module. So if it takes a few days for this to get in place, that is actually quite all right. We want them to be spending a lot of time working with us so we can understand what their issues are, develop a treatment plan with them, implement the plan, make sure that they are stabilized, and then sort of using education as one of the parts of reintegrating them into their lives. And I think that the speed with which we're talking about here, and it will be very effective. And as I said, if it gets hardwired, we're all doing it consistently, and we're seeing signs of that already developing. I'm pretty confident that it should be a good system.
That is absolutely great to hear. And on behalf of members of the committee, I want to say thank you to you and your staff members. Please make sure that you let them know how grateful we are for their hard work and for the everyday care that they give to the children that are custody of DCYF and all the children that you give treatment to. So I just want to say thank you so much. And if there is no other members of the committee that has any other question to Dr. Sack, at this time I'd like to continue with our hearing and like to welcome the presentation by the Rhode Island Department of Education. And with us today we have Anna Riley, the Deputy Commissioner. Welcome, Anna, to the Education Committee.
Thank you, Chairwoman. I think I'll be brief. I think they've already shared so many of the things I was going to share with you, but let me put up our presentation here. Okay. So some of this will be repetitive. You'll see that I'm sharing the same information as Director O'Coin shared about what the BEP or the Basic Education Program provides, that all students who are hospitalized and homebound receive tutoring and support from their districts when there's a significant regression in academic progress. And then the IDEA law, which goes further for our students who have IEPs, which requires a minimum number of instruction of 5 hours per school week for students who are hospitalized. So this may be accomplished through virtual instruction, and I'm happy to hear that that is now in place. I think we've all gotten better at distance learning and with all of this technology through the pandemic. And so just to review what RIDE's role is, what the Department of Education's role is, we're here to support students and families, and we don't get involved until there is an existing dispute. So once a dispute has been brought to RIDE, it is our work to make sure that we provide them with that support. We may have an evidentiary hearing pursuant to the dispute, or we may just simply try to intervene and work with all of the parties to come to some resolution. If it is a student who has an IEP, we work with that student through our Office of Student, Community, and Academic Supports, which investigates special allegations and makes findings. So we would refer those folks to the dispute resolution procedures. That is really our minimal role. And as I mentioned earlier, when you asked the question, we currently do not have any pending hearings for students who are attending Bradley Hospital at this time. And I'm happy to answer any questions you may have. I apologize on behalf of Attorney Catone, who's our head legal counsel. He had a personal emergency and could not join at the last minute, but I will do my best. I do supervise the attorneys, but I am not an attorney, but I'm happy to try to answer any of your questions.
Totally understand that. Thank you so much. So I do have a question. If a district is struggling to provide educational services to a student in hospital and they are asked RIDE for help, what kind of assistance would RIDE offer?
So we have, and we have been working on this particularly for the last several months because of the desperate need for substitute teachers in the state. We have partnered with the Highlander Institute to enroll and to train substitutes for districts. Many times those substitutes could be used to provide tutoring in hospitals. Most districts do like to use their own teachers, except as you know, right now in the middle of a pandemic, it becomes really difficult to ask teachers to go to the hospital to do that tutoring. But being able to use distance learning in the Chromebook certainly provides more opportunities for us to be able to support. But our support has been in helping to cultivate and create a larger core of substitute teachers.
Okay, great. And what sort of academic materials or support should a student or their family expect to receive from their school or district if the student is hospitalized?
So I think as previously mentioned both by the director and by Dr. Sachs, that would have been at some point physical materials, textbooks, paper, that kind of thing. Now with distance learning, most of the items a student would need to be successful could be provided on the Chromebook. Many of our schools are using either Google Classroom or some other academic platform, which can actually provide both the textbooks and the materials necessary for a student to continue with their education.
And my understanding is that Rhode has an education coordinator that works with the school districts and facilitates if a student is placed there by the school district. How does that process work? If you can let us know about that.
So our person simply is a liaison. So it would be someone who connects whoever is at the district if they're not familiar with the process, kind of how the process looks, how the process works. They may connect them directly with either DCYF or with Bradley Hospital. So Rhode simply acts as a liaison between the parties.
Okay, and why does Rhode only works on cases of district placements? Why not every case where a student is placed in a facility, regardless of who places them?
We do get involved anytime there's a dispute. So regardless of whether a student is placed there by DCYF, it could just be, as Dr. Sachs mentioned, most of the students who are there are not placed there by DCYF at all. If a parent had a dispute with the district that wasn't providing educational services, they could also come to Rhode for a hearing. So it's not just DCYF placed students. It would be any student who's not getting the education that they deserve or that they are required to have.
That's good to hear. That's great. And who conducts the hearings described by the DCYF policy?
We have 3 hearing officers here at Rhode. So they are attorneys that work for the Department of Education, and they do all of our hearings.
And how can Rhode make sure that youth are actually receiving educational services when admitted to Bradley, whether the student is there during treatment or after treatment?
So we aren't informed of that unless there's a dispute. So unless either DCYF lets us know or the district lets us know or parents let us know, we would be unaware of students who aren't receiving services.
Okay, so there's no communication other than a dispute, and that's when you will get involved, just for clarification purposes. Any member of the committee have any questions at this time for our Deputy Commissioner? It seems like nobody else or any other person will have a question at this time. Mr. Chaput, do you have any questions or follow-ups? Mr. Chaput, yep.
Hold on 1 second. No, I just want to say, prior to the pandemic, this has been going on, for a long time prior to the pandemic, as far as kids having extended admissions. But I'm really happy to hear Ms. Griffith say that everyone is on board with trying to get a female high-risk facility to help these girls move forward, so they're not in the hospital as long as they are. That's really good news, and I'm really happy that is going to move forward.
Thank you so much. Well, at this time, if there is no members of the committee that have any other questions or comments, we have concluded the agenda for today. I just want to take the moment to say thank you to each one of the presenters for their time on a Friday afternoon, for the diligent, answer to the questions and for the presentations beforehand. Just wanted to make sure that you know that the Senate Education Committee is here to help support the process, and if there is any legislative processes that need to be implemented, we are here to make sure that we could help you through that. But it seems for right now that every department, every organization involved have been able to communicate and at least get the steps that we needed to fix the issue. It seems that there was a lot of communication issues happening. We didn't know who was responsible for what, and the policies that had been passed by DCYF had been addressing those concerns, which I really, really appreciated. So thank you so much for your hard work and for making sure that every children in Rhode Island, including the children in our care of DCYF, are receiving the education that they deserve. That's what we're here for, and that's what we are, obligated to do by law. So I just want to make sure that I say thank you for everybody, and I wish you a happy weekend. And this weekend is a weekend of love, so let's continue spreading love, and especially to these kids that needs it the most. So I really appreciate you all. Have a great weekend, and thank you so much for everything that you do.